Do some initial assessment for the patient. I said, okay, what kind of assessment do you want? Right, so there are several assessments that you're gonna ask for. First, you're gonna start out, I wanna do inspection. What does inspection mean?
Physical assessment?
Looking. Appearance, exactly. Okay, or inspection, that's what it means. So Mr. V, you wanna say, I wanna inspect the patient. I say, okay, you wanna inspect, this is what you get. Do you understand how it works? I tell you, you have a diffuse swollen female leg, for example, who's 5 feet 6 inches tall, for instance, in height, who's tachypnic, tachycardic, short of breath. She's sitting in a high Fowler position, and she has 100% non-rebreathing mass on her. So that information, I'm giving it to you. Understood? Your part is asking what is it that you want from me. You understand? What data you want. What else? I say, what else do you want? I say, okay, I want pulse quality. Okay, or I want a palpation. I say, okay, palpate the patient. So you want to palpate? Here it is. But palpation has several parts to it. Okay, what does palpation mean? Touching or touch testing. All right. So what type of palpations do you want? Say, I want a pulse, the pulse quality. I say, okay, it's rapid, irregular, and bounding. You write it down. What else do you want? They say pedal edema. What does pedal edema mean?
Edema duration.
So this is like a test where you check and see if patient is edematous or not. What kind of a test is it? You're basically squeezing on the patient's extremities, and you're seeing if patient is edematous. When you squeeze on the surface, it stays pitted. Sink. Do you understand? See, like now if I squeeze, it gets back to normal, right? On an edematous patient, when you squeeze, it stays like, stays inside, the little thing stays. Do you understand? Okay? And the degree of the edema, how deep it stays, that there's a grading to it. Okay, you can grade it. So for instance, if we say from +2, 3, 4, or 5, okay, that's as higher the number, as more severe the edema is, pitting is. Okay, so okay, Mr. V, I say, I want to pedal edema. I say, okay, it's +4, for example. And you make a notation for that. Okay, what else you say? Okay, tactile fremitus test. Okay, I'll say if you want tactile fremitus, it's increased throughout, except decreased in the left lower region. You write it down. What other test do you want?
Do we have like an outline of that too? Like on?
No, you don't have. I'm giving it to you. That's why I tell you, take notes. There is no copy of this. You don't get this copy.
Are we gonna be allowed to write things down during?
Yes, yeah, when you come inside, you bring a scratch piece of paper. You bring a scratch piece of paper, you get a clipboard and a pen. You know, bring a pen with you or pencil, and as I give you this information, you're gonna be gathering it, write it down. Whatever you find is important. Now you don't have to write every single thing, you understand? The important ones. Okay? So, understand how it is? Okay. Say, okay, Mr. V, also I want to know about the skin turgor, right? Say skin turgor, it's, you ask for skin, I give you information, it's increased significantly. You make a notation if you like, or you just listen to it for now, whatever. Then you say, okay, Mr. V, I want to know also what's their patient tracheal position. Is that an important one? Okay, you want tracheal, here is deviated to the right. Again, if you remember, you can keep it, don't write it, but if you want, just write it down on the paper, at least you have it in front. Okay? Then you say, Mr. V, I want to percuss the patient. What does percussion mean? It's the tapping technique, but from the back. Okay? So, okay, you want to percuss. Say when you do percussion, there is dullness noted on the left lower lobe. Dullness. What does dullness mean generally?
No sound.
No sound. What condition do we associate it with when there's
Edema.
no sound?
Fluid.
Fluid or
Air.
Or no. When it's air, what sound would that be?
Hyperresonance.
You
Yeah.
understand? Don't confuse.
Yeah.
Or consolidation, like pneumonia or fluid. will be more dull, you understand, more dense. Air, like emphysema or COPD, for example, if you percuss, you hear hyperresonance, more louder, you understand? So I tell you, it's gonna be dullness known in left lower region. I said, okay, you write it down. I said, what else do you want? Are you done? He said, no. I need some more, few more tests on palpation part. What is it? Auscultation. So, okay. You wanna auscultate? Here it is. Coarse crackles throughout and absent in the left lower region, for example. You write it down. You understand? Okay. What else? Say, Mr. V, I want vital signs. That's an important one too, right? To get what's going on. So, okay, vital signs, that's fine. What signs do you want? Say, okay, how about let's start with the heart rate. Okay, heart rate, let's say 150, for example. You write it down. What else? Respiratory rate. Okay, respiratory rate, say I'm giving you 40. You write it down. Okay. Blood pressure. Okay, blood pressure, let's say 180/90. You make a notation of that. And you have to interpret basically what you're getting. Is it normal? Is it high? Is it low? Do you understand? That part is also on you. What else do you want? That's the temperature. Okay, temperature, let's say 97.7. You make a notation. Is it high, low, normal? Is it patient hyperthermic, hypothermic? Is it normal temperature? You make a conclusion based on that. And lastly, what else you want? Say O2 sat. Okay, I say O2 sat is 90% on non-rebreathing mask, and you make a notation. You understand? Those are the parts of the information gathering. It's you just give me what specific test you're asking for, and I'm giving you the result. Okay, and you make a notation, and you gather that information, and move on to the next step. Okay, so this is that was part of your inspection initial part. Okay, after that, you say, Mr. V, I'm not done yet, I need to get some more data, but I want more advanced tests and lab work. I said, oh, okay, not bad. Can you tell me specifically what lab work you want? So, okay, let's start with ABGs, for example. That's a legit test to get, right? More advanced. Right, so for ABGs, I give you ABG results. Say pH is 7.5, CO2 say 30, PO2 50, for example, and bicarb 24. Okay, you write it. So that one is hard to remember. You want to write those numbers so you interpret correctly what's going on, right? What else do you want? Say, okay, I want an EKG. Okay, I say, okay, EKG. You don't have to interpret an EKG. So as long as you mention you want EKG interpretation, I'll say, there is no ST elevation. Okay, it's just arrhythmia, tachycardia without ST elevation. Then you make conclusion, what does ST elevation mean? Or ST, So that means that if no ST elevation, what does it mean? No heart attack, at least. Do you understand? I say, are you done? You say, no. I want also BMP information. Okay, electrolytes, in other words. Say, I want some electrolyte data. I say, okay, what do you want? Say, sodium. Okay, I say, sodium is 130. Say, potassium. I say, okay, potassium is 2.2. You write it down, those numbers. Chloride, say, 84. Okay, what else? Blood urea nitrogen. Okay, blood urea, let's say 10. Okay, and creatinine is 1. What is blood urea nitrogen creatinine associated? Why do you want that data? Kidney function. So blood urea nitrogen of 10 and creatinine of 1. What conclusion do you make? Is there kidney failure or no? So you need to know that. What's the normal criteria for those? Do you understand? Generally speaking, blood urea nitrogen above 10, like 20, 30, 40, 50, already indication of kidney failure. And same for creatinine. You shouldn't have creatinine in your blood as well. Okay, creatinine of 1 is still within the normal limit, or less than 1. Okay, but let's say 1.5, 2, 3, 4, 5. Higher number means kidney failure also. It's kind of additional test for kidney failure. All right. Also know what interpretation of the sodium, potassium, normal values for the sodium and potassium are. When I tell you potassium of 2.2, what does that mean? Is that normal? High? See? What's the normal potassium levels?
3 to 5.
Huh?
3 to 5.
About 5, 4 or 5, something like that, right? So I'm telling you 2.2, what does that mean? Low, okay? Now, why do we worry about potassium? Why is potassium important? What is the importance of potassium's function? Potassium is a very important ion for your heart muscle, cardiac muscle contractility. You understand? Slight variation of the potassium concentration in the blood can affect cause arrhythmias. It's a very important channel ion for normal action potential of the cardiac muscles. Okay, on when you know what that injection on the death row prisoners who are on a death row, and you say they injected something in the through the IV. You know what they get injected with? It's potassium for the most part, unless there is some new things. High concentration of potassium. High concentration of potassium alters that function of the action potential because it freezes the heart. You understand? All right. What else? Okay, I say, are you finished? Say no. I want more. What do you need? I want an X-ray. I say, okay, you want an X-ray? Here's the X-ray interpretation. And I give you the X-ray interpretation. Diffuse fluffy infiltrate with, let's say, blotted costophrenic angle on the left side. What does the definition or interpretation of blotted costophrenic angle associated with? What kind of a condition? There you go, very good. Do you understand? That's how you get the info. Okay? And lastly, I said, you done with your advanced labs? Say, no, Mr. V, I want one more. What is it? I said, you want cardiac enzyme information. Okay, again, I want to make sure my patient's not having heart attack. So, okay, so for cardiac enzyme, you say, I want cardiac. I said, which enzyme you looking for? You have to mention it to me. Troponin. It's one of the name of the enzymes. I said, okay, troponin is 0. Okay, is that good or bad? That's a good number, 0. Okay, why? Because you do not want troponin floating in the blood. When you do that cardiac enzyme, you draw blood and you look at how much enzymes you have in there. Okay, if you have too high troponin levels, what does that mean?
MI.
Heart attack, you understand? Okay, so what other enzyme you look? You say CPKMB. That's the name. CPKMB is the name of another cardiac enzyme. So okay, that enzyme, if you want it, it also comes back to be normal within limits. Oh, okay, you write it down. What else? There's one more, BNP. That's the name of another cardiac enzyme. That one also, I say, give you a number of 670, which is also normal. You say, okay. So then what do you rule out? Huh? What do you rule out based on this data? Heart attack. That patient doesn't have at least heart attack. You understand? Okay? So, does that conclude advanced tests? Yes. Okay, so we're done with the data. Now that you have gathered all this information, basically I'm gonna say, okay, so what's next? So now we can think about treatment choices for the patient. All right? So based on the data, being therapists, let's think about lowering the ventilation oxygenation. Based on the data that I gave you, as part of the treatment, what would you recommend for respiration part? Huh? Very good, CPAP, right? Okay, I say good, CPAP, okay, let's do CPAP. So what settings do you want? You need to give me settings.
Pressure support 10.
Is there pressure support on CPAP?
Half of it.
Huh? Correct.
There is, but you put the iPad.
All right. If you're talking about CPAP, then you shouldn't be mentioning about pressure support, right? You understand? So what settings would you give me then?
502.
Huh? Say it again. Is there IPAP, EPAP on CPAP mode?
No.
That same thing, the same pressure support.
It's only FiO2.
Don't confuse. CPAP is not same as BiPAP, guys. If you're saying CPAP, that means specifically you know what settings you're talking about for
Say
it.
again?
I hope that's what you meant. Did you mean BiPAP or CPAP? So let's start with that. Which one did you initially want to start with? Okay, why?
Because she had electrolysis, or we think she has electrolysis.
Why can't you put a patient on a BiPAP without electrolysis?
Yes, but she's not oxygenating well on 100% FiO2.
Correct. So if your patient not oxygenated, you can't put them on a BiPAP?
You can.
can.
Okay, so but what's the main
It's not a
reason?
ventilation issue, it's an
Patients
oxygenation.
Huh?
It's not a ventilation issue, it's an oxygenation.
How do you know?
You have an ABG?
What was the ABG?
I don't know.
Aha. So that's the one you wanna write down. Do you understand?
What was the
Good.
ABG?
What was the ABG?
7.5,
Yeah.
30,
Give some numbers.
50, and 24.
What was
There
the
you go.
ABG?
50. What else? 7.5,
CO2 30,
30,
and bicarb 24.
24, PO2 50. Do you understand? So do you see why now you don't want to put them on a BiPAP? So if you put them on a BiPAP, what actually will happen? Huh? Acidotic? Why? If you hyperventilate, they become acidotic?
No, if you hypoventilate, they become acidotic because the CO2 stays.
Correct, but when you're on a BiPAP machine, now is that patient hypoventilating already? Is hypoventilating? CO2's high?
It's 30.
See, that's where all the problems start from, guys. You remember what I told you? When it comes to knowing what you're gonna be doing, you gotta first know how to interpret your ABGs correctly. What does CO2 of 30 mean? Is it hyperventilation or hypoventilation? See, some of us say hypo, some of us say hyper. That's what the problem is.
You don't want to CO2, so you have to-
So again, is the patient hyperventilating or hypoventilating?
Hyperventilate.
Hyperventilating. You understand? So if patient's hyperventilating, which mode would you think they have? What's their oxygenation? Is it normal or low?
Low.
Low. Okay, so they're hyperventilating and they're also low on oxygen. So which mode would you recommend?
CPAP.
Why?
Which is oxygen.
What would have happened if you put them on a BiPAP?
They wouldn't have been able to expel the CO2.
Why not? Doesn't BiPAP help with CO2? Blow off the CO2? Legit question, huh? Huh? Not over oxygenate, but over ventilate, guys. Your patient's already over ventilated. Don't you see? It's already it's alcoholic respiratory. If you start adding IPAP and EPAP, or especially IPAP, pressure support, that means you're gonna be lowering their CO2 even lower. You're gonna make more alcoholic. But you don't wanna do that. The guy's doing the job. What's the problem? Why do you think he's even hyperventilating?
Low O2.
Because of the O2. So what is the main thing you wanna target?
Increase O2.
There you go. So which one would you use again?
CPAP.
Do you understand now?
Yes.
I hope you understand it. You don't just remember it and memorize it. Let's go. Okay, continuing. So what settings would you use on a CPAP?
CPAP of 8.
Huh?
Set the FiO2.
Which FiO2?
Just set the FiO2. Less than 50.
Set the CPAP pressure.
Set FiO2? What does set FiO2 mean? Oh, you mean you set the FiO2?
Yeah.
Okay, so my question is, what FiO2 would you set? That's what I want to know. I know you're gonna set the FiO2, but what is it? 30%, 40%, 50%, 100%? What?
About 40%. Say 40% FiO2.
Oh yeah?
Started off
What
at
was the
40.
PO2?
50.
On how much FiO2?
100, start on 100.
Is that good or bad?
Start on 100.
So if your patient's PO2 is only 50 or 100% FiO2, if you're putting them on a CPAP machine, what FiO2 you want to use?
100.
Thank you very much. Do you understand? I hope you do, instead of memorizing it.
I didn't write anything down.
How about PEEP? Is there PEEP available?
Nope.
Yes.
I know, I'm joking. Yes, sir.
Oh yeah, that's
Yes,
good.
sir.
I like that. So how much PEEP would you use?
People.
At least 5 is a good answer. Don't be afraid even going with 10. What do you think, first of all, these patients' problem? Based on the data that you gathered. First of all, now you have to think about that. What are you dealing with?
Oxygenation.
Okay, but what's the problem? The problem, what is the problem? Due to what? Oxygenation, problem due to what condition?
Atelectasis, I think you said in the left lower lobe.
Also, that's a contribution, but what other? Is that atelectasis the only thing you think is going on with the
Pleural
patient?
effusion, CHF.
CHF, also contributing factor, biggest one. What was the breath sounds like?
Course.
Dullness.
Coarse what?
Crackle.
Coarse crackle. What is the definition of a coarse crackle for breath sounds? What is that? What condition?
Fluid.
That's
Fluid
defined
buildup.
generally. Generally, fluid is a general term. More specifically, it defines what? Thank you very much. Do you understand? And yes, patient also has some effusion going on too. That's an addition on the top. Understood? So if your patient has pulmonary edema, CHF, would PEEP help? PEP.
Yes.
There you go. So how much would you use?
10.
10 would be a good, don't be afraid of that, this point at least, because they're loaded up with fluid. You're not gonna hurt them. You wanna open up those alveoli, push that fluid out, do you understand? All right, continuing. So besides CPAP, so you start with the CPAP, what else would you recommend for choice of the treatment based on what you gathered on this patient? What other medications would this patient benefit from? Huh?
Lasix.
Nice, I like that. Did you hear what Alejandra said?
No.
What, say it loud.
Diuretic?
Diuretic. Do you guys know what diuretic is?
Makes him urinate.
Huh?
Makes him urinate.
Correct. Do you have a name of one? Lasix.
Yeah.
Remember it. Okay? So yes, diuretic would benefit the patient. All right? What other medications would you consider? Mucomist, usually for pulmonary edema, no. Because they're not that they have a problem.
You said he had high potassium.
could, yeah.
You said he had high potassium levels, right?
They had what?
High potassium levels?
Did they have high potassium levels? What was the number? What did you write?
2.2.
Or did you write?
Oh, it's low, that's
Why
right.
do you think I'm telling you to write? For fun?
No.
So,
Yes.
so what was the potassium level?
2.2.
Is it high or low?
Low.
Low. So if it's low, what would you give?
Potassium.
There you go. So you can say, Mr. B, let's do some supplemental potassium. It should be your one of the choices for the treat.
And that would help with the ability because it helps the heart beat properly.
Which one?
And that would help with the heart beat properly, so it would help with fluid.
Mostly the potassium just will help with the potassium level, which also for heart function overall normal function is important. But now that you mentioned what condition patient has, what's wrong with the CHFers
Fluid.
for heart?
Preload.
Huh?
Preload.
Or what's the contractility? The pump, is the heart pumping good? It's
Flutter.
weak pumping, right? Weak, weakened out. That's what congestive heart failure. It's a chronic heart failure. So there is such things as medication that will increase contractility, known as positive inotropic drugs. You learn about. You're supposed to learn, from what I understand, later on next semester, if I'm not mistaken. But you can also consider or recommend, not even consider, but you should also mention, Mr. V, we're gonna give some positive inotropic medications to to increase the contractility of the heart. And I said, what kind? You can even give me some names, digoxin or digitalis. Because I like the names, digoxin and digitalis. You can mention it, remember it. Okay, to impress me, or whoever is
So
going
you
to
said
be
they're
there.
positive, what?
Positive inotropic drugs. They're cardiac drugs. Okay, good. And also, what else did you notice when you were getting the information for this patient that caught your attention? Or did anything else catch your attention?
High blood pressure.
Nice. What's your name?
Ian.
Ian. Good job, Ian. No, I'm joking. This people likes to joke. So, that's right. What was the blood pressure like?
180 over 90.
180 over 90. Okay, that's high, right? If you want to keep it that high, most likely patient will have, it's not good. So there is such a, so you can recommend medication to lower the blood pressure. You can say, Mr. V, let's recommend some blood pressure medication because the patient's blood pressure is high. And what am I the name of, more specifically, if you want to be specific, you can even mention sodium nitroprusside. Sodium nitroprusside. Okay?
You said Prozac?
Sodium nitroprusside. Yes. Okay? Okay? Is that all the problems that the patient has?
It was also,
No.
they were also tachycardic, I think you said in the grade of one.
Tachycardia, that's correct, but if we try to take care of his oxygenation on all the other issues, tachycardia is associated more from that, yes. But what else did I want to say? What other medication, or what else is going on with the patient? We said they has pulmonary edema due to CHF, and what else? Was it pneumonia? Huh? Based on the x-rays, based on the breath sounds, and
Pulmonary
percussion,
effusion.
what else you think he has? Is it atelectasis on the x-ray? What does x-ray say?
Blunting of claustrophrenic angles.
Blunting claustrophrenic. What was that definition of what condition?
Effusion.
Pleural effusion. Pleural effusion is not same as pneumonia, guys. It's a different condition. What is a pleural effusion, by the way?
Air in the throat.
Water.
No.
Fluid in the air.
Fluid in the pleural space.
Yeah.
What is the air in the pleural space called? Pneumothorax.
Pneumothorax.
So this patient at this point has a pleural effusion. What is the treatment for pleural effusion? Initial treatment, do you know?
Thoracentesis.
Thoracentesis we can start with. You can say, okay, Mr. V, for the pleural effusion, let's do thoracentesis procedure, and you can say it's left mid-scapular thoracentesis. You mentioned it, that's good. On the left side, at least we know which side it is. Do you understand? And that should be the whole selection of your initial treatments. You need to mention those. Do you understand, guys? You just gotta make sure you remember. That's why we're reviewing now, so you guys have enough time, with a lot of things going on, at least to practice it, and you need to study. But yes,
Is that the same one we're gonna get, or?
yes,
Okay.
yes. Before, only because this is the only one I have time to review with you guys. Back then, when I had my own exams, my own schedule, and my own things, time was more manageable. I had 3 different. I had a COPD patient. I even had an ARDS case scenario, and you would have to pick all 3 of them, and you would have to pick
Nice.
one of the 3 papers.
I got
You
you.
just pick whichever you get. You have to answer for that one. But because of the limited, simply I don't have enough time to review all 3. Which is plus this also incorporates.
Same one.
I picked this one also because it incorporates basically a lot of stuff that we covered during the lecture, like non-invasive ventilation, mechanical ventilation is included here. That's the reason I picked this one. So just make sure you know at least this one. Do you understand?
Yeah.
Alright, so now that we started the treatments, next thing coming up,
Not
I'm
bad.
telling you information, you listen. Couple of hours later, after you start all these treatments, patient being placed on the CPAP and all the everything else, the nurse calls you, you assess the patient, and you notice that the patient is unresponsive at this point. Okay, she's breathing at only 6 breaths per minute. Alright, and heart rate is only 50, sinus bradycardia, and she's unresponsive. What should your first initial action be?
Start back.
Excellent, very nice. I'm back. And what else you do while you back? Call what?
911.
911. Not 911. Call for help. You're in the hospital. You got me this one. That was good. 1-1 the score. So it's 9-1. So you call for the doctor. The doctor comes in. He looks at the situation. You're bagging already. Correct. What do you think he's gonna say?
Intubate.
Let's go ahead and intubate. So you go ahead and you intubate. The doc is a new grad, medical school, doesn't know anything about respiratory. He's asking you what mode and settings are you gonna recommend?
ACVC.
Good. What rate would you recommend for initially? There you go. You can give me a number.
12 to
14,
16.
16. Okay. Tidal volume.
450.
6'1",
Tidal volume you can do both ways because the patient's height there. You can do the calculation if you like. Okay, with the ideal body weight and all that stuff, or you can, to make it fast, because we don't have, you can say between at least 400, 500, Mr. D. That's fine enough also. All right. Okay. Are we done though?
Peep.
No PEEP. What PEEP? How much PEEP would you use?
5.
Keep the same PEEP as you was on the CPAP. How much was it?
10.
So keep it at 10 for now. How about F5?
100.
100.
Also 100% as it was on the CPAP machine. You understand? But are you done with the ventilator? Alarms,
Yeah.
thank you very much. Remember I told you before, we're gonna come back to the alarms. You guys remember the numbers and the limits I gave you? Alright, so I'm gonna say, okay, the alarms, tell me about the alarm limits. At least you have to verbalize it with me. What are the limits, they say for, you're gonna say, okay, Mr. B, for the respiratory rate. What's the limit range that you set it at?
40.
30.
Huh?
40 high.
What?
40 high.
No, that's not how we look at it. What's the range? 10 above or 10 below, or 10 to 15
Oh.
above or below from whatever patient's doing. You don't know, maybe patient's baseline is 40. You understand? Or 30. See what I'm saying? So you just say 10 or 15 above or below. Okay, what other alarm limits do you want to mention? Tidal volume, okay. What's the range for the tidal volume?
100, 150,
Nice. What?
above and below.
What are the units?
Milliliters.
mLs. Do you understand? Okay, we got the tidal volume. What other limits we can talk about?
PIP.
PIP is excellent. What's the limits for the PIP range?
5.
There you go. So you said for the PIP, Mr. B, 10 to 15, above and below. Good. What's the last one we can talk about?
Apnea.
Apnea?
Oh wait, no,
That's a separate
Yeah.
thing, but that's good. I'm glad you mentioned it. Yeah, you do your apnea settings, but you don't have
Minute
to.
ventilation.
Minute ventilation alarms, right? There is such a thing. What's the rule for the minute ventilation?
20 over 4?
Say it again.
Sorry, I was giving you a value for like, I typically see 20 over 4, but I can't remember the range.
Correct, that's what you see, but by the book, what did I tell you? The range, the upper range and
Think
the
so.
lower.
Say it.
Again, 2-3 liters per minute, it should be above and below whatever
2-3.
patient's minute ventilation is. Now, yes, you're right, in clinical settings, when you guys go do your vent checks, you look at those alarm settings and stuff, you see that the ranges are way out from what we've been talking in the classroom, right? That's just being in the real world. But for your exam purposes and stuff like that, remember what we were talking on the slides for the exams and for what I'm giving you here. You understand? Okay? Okay, so you do that, okay? You put you mention the settings, you give me the ranges for the alarms, we're good, we're moving on. Next thing what we have is that 1 hour later you do a blood gas. Is that a legit thing to do?
Yeah.
Okay, very good. So you do blood gas, okay, and here's the EBG results. I'm giving you the result. pH say 7.38, CO2 let's say 42, PO2 400, and BICOP 24. Next thing I'm gonna ask you, what should you do at this point?
Green down oxygen.
Which one?
Oxygen.
see
Good,
400.
okay. What's the increments usually we go by?
That's fine.
5 to 10% of the time you can go down to. Less than 60% or something like that. Do you understand? Alright, so yes, PO2 is what stands out.
You see PLC's at 400?
Yeah.
So following day, you do that, following day, you have the patient in ICU, okay, and the nurse calls you over again. Says, can you please come check the patient? The high pressure alarm goes up with every breath. No, alright? And you note the following, you listen to the breath sounds, and you see that the patient's breath sounds decreased on the left side, and trachea is deviated to the right. Okay? You percussive dullness noted in a halfway up the left thoracic cage again. Alright? What would you recommend at that point to verify your suspicion?
So
The
is the
trach was deviated to the right.
To the right.
You said what on the left? It was diminished?
Yes, dullness on percussion noted halfway up.
Chest
the left-
X-ray.
Halfway up the left thoracic cage.
Chest X-ray?
X-ray, yes, to verify whatever you suspecting, okay? And the X-ray, you say, Mr. V, X-ray, so on the X-ray, I say you have a large pleural effusion on the left side again. Alright, so what would you recommend at this time for the treatment? Chest tube, again, say, Mr. V, chest tube, let's on the left side, okay? Good, so you insert the chest tube, a few days later, patient is again awake, alert, alright, I'm giving you that information and you're listening. The chest tube's been removed, patient is on low SIMV settings now, okay, with only 30% oxygen or 40% oxygen. And doctor wants you to place the patient, to place on spontaneous breathing trials, okay? So what would you recommend for that? To start spontaneous breathing trial.
Switch to SIMV.
Patient is already on SIMV mode. From what I'm told you, I'm telling you, a patient on low SIMV. So which mode would you place them on?
CPAP?
Spontaneous or CPAP mode, good, okay. Then I'm gonna say, okay, what are the settings for the spontaneous or PSP mode that you need? Huh?
Pressure.
Pressure what?
Support.
What, the full name of the pressure, because there's all kinds of pressures. Pressure, support, say support. Don't just say pressure, because I don't know, is it pressure control, peak inspiratory pressure, P pressure, which pressure you talking about? You understand? So spontaneous mode, pressure support. Okay, good. So how much pressure support would you recommend? Minimum.
15.
That's okay, but that's a little too much.
10.
12.
What's the minimum pressure support I told you?
5.
About 5-6, right? Why 5-6?
Because it's almost nothing.
Just enough to overcome the resistance of the ET tube.
Right.
What other settings do you want for the PSV mode? Yes, you can get to 15, but that's a lot of help. Okay? And since we're trying to extubate, we want to say, keep it as low just to see how much actually patients doing on their own.
CPAP.
Huh?
PEEP.
PEEP and FiO2, the other two settings pretty much you need to mention. What PEEP would you use? 5, that's right, because for the winning, if you're already winning, 5 is where you don't want to do 10 again. You understand? How about that 5? 30 is fine if you say, but 40 if you say is good.
What do you think of the pressure support and feed?
8, again, I have no problem with 8, but if I'm extubating a patient and want to get a good actual picture how they're doing, I'll have them on pressure support 5 or 6. 8 is already giving a little extra that can add to their own tidal volumes, actual volumes, so I might have some misleading information.
Right.
You understand? But initially, if your patient needs 8 or even 10 or even mentioned 15, let's say actual situation, if your patient is short of breath or pressure support of 6, then I will increase it to 8, 10, or 15. Do you understand? That's a different situation. Okay, but then I'll make conclusions, okay, on pressure for 15, I'll let him do some weaning trial on that, but I'm not gonna extubate it.
Stop.
You see how I'm gonna change my thinking? Okay, good. So while also on a spontaneous mode, there is such a thing, which I didn't see on the slides, by the way, this time. Before I had these PowerPoints part of the slide too. We didn't skip any lectures, did we? We covered chapter 9, we covered everything, right?
Yeah.
See, now on these slides, I didn't see it because they've changed it again. They changed term to term,
Lead
unfortunately. But there is such a thing as winning trial criteria, some measurements that you look for. Rapid shallow breathing index, remember when I mentioned? Being one of them. So while patient is on a spontaneous mode with pressure support of 5, you do the rapid shallow breathing index. You also say, Mr. V, now I'm gonna do rapid shallow breathing index on this patient, just to see if they're ready or not, you understand? So, okay, you do rapid shallow, good. Then you do the test, the calculation, it comes out to be 50. You write it down, RSBI value came back 50, okay? What other test do you wanna do? There is such a thing as additional test as NIF, negative inspiratory force. NIF, negative inspiratory force. It's a test too. Okay? That's a test just checking how strong the patient's skeletal muscles are. And you know how you do it? Actually, on a ventilator, there is a place setting where you put the patient on, you put the NIF, you start the NIF, you push that NIF button. And at the same time, you ask the patient, because when you're waiting, you're assuming your patient's neurologically also with you. They have to be alert and more or less understand what's going on, okay, and follow your instructions. So as you try to do the NIF, as you press the button, you tell the patient, okay, take a deep breath in, while they're still attached to the ET tube. And they're supposed to inhale through the ET tube. And when they inhale, the machine measures how much force they generated with inhalation. Okay, do you understand? It measures how strong your muscles are. Okay, inhalation muscles. Right. So the minimum acceptable the patient has to pull should be at least minus 20 centimeters or higher. 30, 40, minus 30, 40, 50, 60. Do you understand? Higher that number is better. If my patient does the NIF test, and they only create minus 8 or 10. Is that acceptable for extubation? That means they're not ready, do you understand? Quite often doctors, sometimes some hospitals, they look at NIF too. They don't look only on the RAP. Maybe the rapid shallow breathing index is passing, but they do the NIF and they see that patient's only pulling 8, 10, or 12, 13, 14. All right, say, you know what? He's still weak, so we're not gonna extubate. You understand? Okay? So in our situation, we do the NIF test and we produce, let's say, minus 50.
That's good.
You write it down, say, okay, from what I just told you, that means it's above 20, that means it's good too, okay? So but there is one more test out there, known as a vital capacity test, where the same patient with the same way on a vent, you press the VC button during that test, and you coach the patient, take a deep breath in and exhale out as strong as hard you can. And it looks at how much volume in a full deep breath patient is moving. Okay? And the minimum acceptable for that should be at least 1,000 mLs or higher, or in other words, 1 liter or more. You understand? If patient produces above 1 liter, that means there also tells you about, it's a breathing muscle test, tells you how strong your muscles are. All right, and if your patient produces more than 1 liter, and in this example, I say, you ask Mr. V, I also want to see vital capacity test result, I'll tell you 2 liters, and you write it down. Is that good or bad? Okay, so once you gather all this information, all this data, upon completion of your assessment, doctor would like to ask for your recommendation. What are you going to recommend? Extubation. That's it. You say, Mr. V, let's extubate. You do that, you get checkups, completed points. Now, as you go through the test during the practica, if you're missing recommendations or the tests that you wanna check, you get deductions for it, you understand? You give me all the steps that I told you, you get points for it. You understand how it works? And it's gonna be out of 50 points total. Good? Questions, issues, concerns?
This is graded in the 2310 course.
Yes, part of your final exam, this is practical. On Wednesday, 8 o'clock. Practicum is gonna start at 8. Okay? First come, first go basis. I'm gonna have 2-3 more people coming helping us because of the size. Alright, so we can finish on time. Because you see how, it takes a little time to.
Who's gonna
per
come?
student.
Who's coming?
I don't know yet, but usually I have, either Morales helps me, we have a few other clinical instructors that they hired. They should be available too in case. Good,
My
guys?
camera follows him.
Questions, issues, concerns? Alright, so in case you have questions coming up, next week is also time to ask regarding the practice, in case something's missed something, you still didn't understand Mr. V or this section, or what was I supposed to do and stuff. But you need to study. It's not that difficult right now, okay, but you